Good afternoon. My name is Ron Lynch, and I am completing a prevention project in the behavioral theory class. Dr. Pomerantz is the head instructor of that. And this class is pertaining to the subject of Healthy People 2030, and specifically breast cancer amongst African American women is the targeted population that we're looking at today. The question is asked, how many women are affected by breast cancer in this country? 264,121 women were diagnosed in 2019, and there were 42,280 women that died that year. So out of every 100,000 women, 130 females will be diagnosed. Unfortunately, this may also include men. And so in this year of 2023, it's predicted that 530 men will die of breast cancer, unfortunately, out of the 43,700. And so this map or this graph reflects the data that I just told you. Now, what are the health outcomes associated with breast cancer? Breast cancer will affect women in various ways, but physically, emotionally, and mentally. And there may be changes in a woman's body shape after she undergoes a biopsy or a mastectomy. She may have to deal with alopecia by way of the chemotherapy. And some of the medication may cause her to go into an early menopause with a loss of fertility. Women will generally experience shock, anger, anxiety, depression, may feel isolated, loss of self-worth, and maybe even having some spiritual confusion. Some of the more serious side effects beyond the alopecia, which is shown here, could be the fatigue and also the lymphedema, which happens when lymph nodes are removed from or near the armpit. Now, if the tumor has metastasized to a distant part of the body, the 5-year survival rate goes down from 86 to 30%. And it's even 10% lower in Black women. There are several factors that can influence breast cancer, from lack of vitamin D to lack of melatonin, perhaps ionizing radiation, tobacco, breast density, you name it, it's all here. There are certain signs and symptoms of breast cancer that you may want to just take a look at here. And there are certain factors that put you at higher odds of getting breast cancer, like just getting older, obesity, if you've never breastfed or never had a pregnancy, dense breast, fibrocystic breast, if you've used HRT, there's certain genetic mutations. And so be aware of your risk factors for breast cancer. Now, some of the subgroups that are most affected are identified right here. And if on this axis, this is the number of new breast cancer cases. This is what we would typically call incidence. And women of Caucasian persuasion are at the highest level, followed by African American, then American Indian, Alaska Native, Asian Pacific, and then finally Hispanics have the lowest incidence of breast cancer. However, African American women have the highest death rate, as well as developing breast cancer at earlier ages. The white, Asian, and Pacific Islander women are more likely to have localized breast cancer where it didn't spread. And Asian and Pacific Islanders, however, have the lowest death rate. Just getting older and being a woman is a risk factor. Now, the gap in breast cancer incidence and outcome among Black women. It's a very complicated, multifactorial challenge, which involves social, economic, and behavioral factors. Black women are more statistically likely to have diabetes, heart disease, obesity, less likely to breastfeed after childbirth, less likely to have adequate health insurance or access, may not get the appropriate earlier screenings, and may not complete all of the therapy. On top of that, they may be socked with something known as the triple negative breast cancer, where the estrogen, progesterone, and HERS2 receptors are all negative. I hypothetically said I was going to address the District of Columbia females, where there is a higher mortality rate. In fact, it's 40 times higher among Black women there than white women. And this is also some incidence rates and also incidence by race. And so I'm going to represent theoretically the University of Maryland in the academic arena. And with my staff, we're hoping to develop a partnership with the District of Columbia to lower breast cancer morbidity and mortality. And so first, we're going to study the demographic statistics from reliable sources such as the CDC, the NIH, the state data. We're going to invite certain key stakeholders of the District of Columbia, community leaders, the health departments, emergency department representatives, agencies of community membership, local churches, interested businesses, to be part of a large consortium. And we want to draw on the strengths of the community, on both the actual DC community as well as the academic community, to become public partners in a culturally specific prevention program, all uniting our forces to one single goal. And so a community outreach specialist may join with our university-based coordinator to develop a matrix of leaders, influential people, providers to build some community capacity. We want to recognize the community as a unit. We want to build on the strengths. We want to collaborate with the partnerships, integrate knowledge. We want to do some learning, co-learning, and empowering, ultimately to address these problems from a comprehensive point of view and to disseminate the findings and the knowledge gained to all partners. There are several models that we can use. There's a social ecological model where we're dealing with the individual, the social networks, the organizational level, the community level, and the policy level. On the individual level, what's her knowledge about or attitudes about mammography screening at an early age? What's her knowledge about endocrine disrupting chemicals, harmful cosmetics, pesticides, or plastics, which play a role? What's her stress level like? What's her lifestyle choices like? Her income, her education, her social status. And what kind of friends does she have? Peers, are they good partners? Are they healthy relationships? What kinds of influencers are around her? And what's her family relations like? What kinds of habits does she have? And if we go higher, we want to know about her school, her work, her neighborhood, what kind of churches she attends, civic engagements, the social groups that she's with, what kind of cultural norms is she accustomed to, and is she the subject of structural bias and environmental justice? This is a great social ecological model. And within this model, if we use the health belief model, we're going to work on discussions of her perceived threats of developing breast cancer. And ultimately, we hope that she will understand that there are certain benefits. So perceived benefits can happen after early screening and avoiding certain harmful substances and making better choices. What kinds of supportive relationships is she in? Is she part of organizations that are also supportive? And Does she attend certain social outfits where she would hear messaging about breast cancer by influencers that are trustworthy, great persuasion, and have her cultural identity? We also want to invest the politicians to make sure that they try to provide as much affordable and expanded healthcare benefits as possible. Black women have barriers to getting their full share of care. And that could be implicit bias from healthcare providers to financial factors, and just the delays that come with life's challenges. Now, there is an intersection of the social ecological model with the social determinants of health, and where those meet, we find that racism, social biases, and inequalities can cause a woman to feel diminished, can cause her to feel virtually invisible in a process we call weathering, where day after day, drip by drip, it produces chronic stress and ongoing adverse events, and that is likely to be a precondition to an early demise. When you look at some of the models, there's one called the precede proceed model. What we want to assess from this community is what their assessment is in terms of quality of life. And we would get that through questionnaires, surveys, interviews, and we're trying to understand what are their hopes, their needs, their beliefs, what are their priorities. Then we would go into an epidemiological assessment by trying to understand what are the mortality and morbidity risks in their lives. What are they dying from? What are they getting sick from? What are the risk factors that they have to overcome? What are the barriers to them having optimal physiology? And some of this is done through quantifiable metrics. Next, we want to do an assessment looking at their behavior and lifestyle, which is all part of phase 3. We want to know about their bad behaviors, the cosmetics that they may be using, endocrine disrupting chemicals, obesity, diet, alcohol, and do they have any preventive habits? We're going to ask about their actual environment. Are they near or associated with any Superfunds, any safety and crime in their neighborhoods, air and water pollution, walking trails? Do they have access to that in their environment? Some of the predisposing factors that may lead to bad behavior are the cultural norms that they are a part of, what their knowledge base may be. And we also know that there are certain enabling factors that we want to introduce. We want to introduce early mammography and possibly thermography and through mobile screening. And there are certain reinforcing factors that we want to provide, such as lifestyle classes, so that they can emulate and develop skills and attitudes that say that they can succeed. We've got to also consider the resources to do many of the things that we want to do, because we want to do a full program having a long-lasting relationship. We're going to make certain process evaluation assessments by understanding how many people attended the meeting and what kinds of responses that they may have with the evaluations. We may not know for 3 to 5 years what the full success of the program may be. That may be how long it may take in order to get a full outcome evaluation assessment. The headlines are very clear that Black women have a higher cancer death rate than white women, and you need to be screened earlier. And according to the Healthy People 2030 project, we're trying to eliminate health disparities. We want to attain better health literacy to improve health and well-being for everybody. But it may take rethinking health policy, it may require participation of legal, regulatory, and policy interventions that will address discrimination, improvement in medical care, and helping to narrow the financial and medical care gap. In this program, we're trying to promote earlier screening, increase awareness of endocrine disrupting chemicals, and improve lifestyle. Part of the screening may be something like Feel It on the First, where women are taught to do self-breast exams on the first of every month. But screening is a very critical thing, and that might even involve thermography. In order to really be successful with cancer prevention, we have to look at things from a social, scientific, economic point of view, and we have to value human lives over trade and business. That's the mechanism that we're going to have in order to succeed at breast cancer prevention. But even if we can just reduce mortality, we're going to be successful. Breast cancer prevention can happen in our lifetime, but all hands must be on deck. This is a prevention project presented by Dr. Lynch. Dr. Pomerantz is the instructor, and I want to thank you for your time and attention to this subject matter.